in the number of patients meeting that goal by the end of our 13-month study period, but you can see that for our intervention group, 54% of patients had actually reached their A1C goal of less than 8%. Again, we did also look at the percentage drop in A1C. We found that to be significantly lower for our intervention group. So for all patients included in the study in the intervention group, we saw a 1.4% reduction in A1C. When just looking at our two subgroups who had an A1C of greater than 8%, that was actually a 2% reduction. And what I find to be most incredible is that when we actually looked at the number of anti-diabetic medications that patients were taking at the end of the study, it was the same. So 2.3 medications on average for both patients in the intervention and the usual care group. We saw something similar when it came to blood pressure. So again, as I spoke to, the intervention group had a significantly higher rate of blood pressure goal attainment by the end of the study. That was at 93%. However, we did just see a reduction that was significant in systolic blood pressure, but that did come down by 7.4 millimeters mercury. Interesting enough, though, again, we saw that there was no significant difference in the number of antihypertensive medications that patients were actually taking at the end of the study, even though we did see this increased rate of goal attainment. So in summary, pharmacist intervention within our UC Davis Health System, PCN, resulted in improved therapeutic outcomes for A1C goal attainment and also blood pressure. And this has a huge potential to play a key role in delivery system reform. So again, adding a pharmacist to your care team can again help to enhance your ability to achieve those pay-for-performance goals. It is likely helping to lower healthcare costs, utilization, and of course reducing the risk of disease-associated complications. And one thing I want to make sure to definitely highlight is a pharmacist's unique ability to, again, kind of work towards medication optimization. And I think this study really helps to show that that optimization does result in better outcomes. So again, we saw improvements in A1C and blood pressure goal attainment rates without actually increasing the number or the average number of medications that were prescribed to patients. And I think some of the reasons that we saw this were for our pharmacy team, we are utilizing motivational interviewing techniques. So we are kind of openly speaking with patients, figuring out what their goals are, how they're utilizing these medications to help them initiate change behaviors to get them towards their goals. Also, I think the interventions that we make frequently, again, help to support this medication optimization. So it's medication dose adjustments, drug adjustments. So again, looking at the regimen that the patient is on and seeing if there's room to optimize those therapies to, again, get them towards their goals. So again, reviewing if these medications are working and if they're not, getting rid of them to, again, simplify the patient's regimen and help them move towards improved control. We also, again, are actively addressing medication barriers that patients often face by reducing medication drug costs through a number of different resources, implementation, again, of self-management tools, so finding out why patients are not adherent to their therapies. If it is that they just forget to take them or they have a hard time with transportation, maybe we're getting them set up with a pharmacy that delivers the meds to their doorstep to, again, make sure that we're giving patients the tools that they need to effectively use these therapies that we're prescribing. And then, of course, we're always at each visit providing educational resources and patient-specific counseling. So our next steps, so we're working towards placing pharmacists on the care team in all of our PCN clinic sites at UC Davis. I'm happy to say now that we actually have 4 pharmacists that are located at 6 actually of our PCN clinics. So we're continuing to grow. We also have 3 pharmacy technicians to, again, expand our prior authorization team. So there's a lot that we're doing to, again, kind of support the results that we've seen and continue to be a value-added member of the care team. We also have expanded the pharmacist's clinical responsibilities. So outside of just chronic disease state management, we're now also assisting with pain management and anticoagulation, including DOACs. We have had built an EMR pharmacy e-consult, which should be going live soon. So just another way to kind of best utilize the EMR and those technologies out there to make sure that the clinical staff is able to easily access their pharmacist and get the answers to the questions regarding medications that they have. And we've also continued to actively work to align our services with the institution-wide metrics to, again, make sure, not just within our clinics, but on a health system-wide basis, we're, again, ensuring proper medication use. with all those positives, I'll say we're still working to define value. I know we were just talking about this earlier. It is a challenge to, again, kind of show that return of investment, and I can say in our case, in our clinic, we're not currently billing for our services. So it's something that we continue to work towards to make sure that we're showing, whether it's monetary, whatever it might be, the value that pharmacists are truly adding as a member of the care team. Okay. It's time to open it up to some questions.
I have a question. I was just curious, how do you track patients who have hypertension or diabetes as a chronic condition? Is it patient-driven? Do you have a registry? Is it pharmacist-dependent to have like their own list?
Good question. So the question was, how are we tracking these patients and identifying them? I would say currently, at least for our clinic, I know it's probably going to be different for each of the pharmacists. We are right now completely PCP driven, so it's completely based on PCP referrals. We are working towards capturing these patients on more a population health basis. So I think it's something that we're moving towards, but at least at our clinics right now, we have kind of moved towards just solely a PCP.
So you'll get them in control and then turn them back, and
exactly.
2 years later you could get the same patient.
So it's quite possible that 2 years later we could see the same patient, but basically they're referred to us, we help address their medication concerns, and then send them back. I would say often though with the relationship that you develop, it's very hard, at least for me personally, to discharge patients from our clinic. I would say often that they might be referred to me for their diabetes, and we get their A1C to, let's say, less than 7%. They still have my contact information. So oftentimes, even though we've addressed that one medication issue, something else might come up. Maybe 6 months later they have a hospitalization and they're coming to me because they're confused on how to take their discharge medication. So I would say, at least for our clinic, we've kind of kept that door open to make sure we're kind of meeting all of their medication needs. But it's a great question.
At UCSF, we have now decided to purchase the greater Epic, which includes, what is it called? What is the platform called where we can do population management? Healthy Planet.
We're moving towards that.
Thank goodness. I don't know why it's taken so long to do this, but we're hoping to utilize Healthy Planet for automatic referrals to me. So if the blood pressure is above a certain number, they'll just get an automatic referral to our pharmacist. That's what we used to do at my clinic in Ohio, which was excellent. And so we're hoping to do that, but as of right now, very similar to what she said, I have patients who I got to their blood pressure goal, and a year later they call me and they're like, Rose, I don't know what happened, but my blood pressure is going up again. So I think that once you develop that relationship and they know you're there, they utilize you and they'll continue to utilize you, and if they don't know how to find you, they will find you. Because they will message their cardiologist who will say, remember that short blonde girl that helped me. They usually remember my name, but my last name is really long, so they tend to forget sometimes. So I think that right now we're just still trying to figure out how can we best utilize the system to help us, and we're in the process of using those resources.
Yeah, I think that, the key
Could
point
you say what organization you're with?
So I'm Karthik Kumar, and I work with SIP as well as with Captain Nephrology Medical Group.
Sutter
Southern
IPA. Thank you.
Thank you. So I think that with regards to whether it's chronic disease or whether hypertension, diabetes, and end-stage disease, which I see a lot of, I think that the most important thing is leveraging different tools that are available to us, whether it's healthcare technology, whether it's use of wearable technology, mobile health, or collaborative work. So I think that the paradigm is not about just having a pharmacist. How about a dietitian? How about X, Y, and Z? So I think the barriers that are there to population health definitely apply to all of this. How about use of AI, which just circumvents all of this, which kind of just says, hey, you know what? If the blood pressure is such, refer here. So why do you have to have a physical person? The financial barriers of insurance, the physical barriers of visibility. My patients have hypertension and diabetes. How many of them own a smartphone? How many of them, here you're giving out freebies in terms of a free blood pressure cuff. So there are numerous barriers, but I think the operative learning experience from this is leverage of use of different collaborative pathways to improve population health. But I think that it has to be not only a top-down approach, I think it has to be a horizontal approach where it's not only about us in terms of having a pharmacist, but also having providers, population health matrix, legislation, policy changes, all of that to allow that. And so is that going to happen? I don't know. And
Can I just
secondly-
add on to what he's saying, which is that what we see in this data that Megan worked so hard to put together for us across our 4 major cities that we're working in, is that the independent practice associations like Sutter have the greatest challenges in achieving the goals. We have to think differently when we're talking about the smaller practices that are associated through the independent practice associations, and so I'd just like to hear your thoughts on what we do about that.
That's a very good question. I guess to speak to what you're saying, we have to understand each other's roles in order to work together. And so I think that it's really important for us in every realm of healthcare that we continue to do things like this and learn from each other and understand what we can do to work together. And I completely agree with you. We have to figure out what our resources are and then use them. And if we're not going to do that, we're not doing the best that we can to take care of our patients. So I'm not sure really.
There isn't an easy answer. I'm just throwing it out there that the Independent Practice Association providers don't have the critical mass. And so one of the things that came out of the study that Dr. Hirsch did with Dr. Carol Mangione at UCLA during our initial NIH study was to say, okay, now that we've gotten these just stunning results of you add the pharmacist, you quickly get the patient into good control, but how do you extend that? What is a cost-effective way to extend that out into the community? So what Carol Mangione had suggested is that maybe because in that independent practice association setting, you can't have the pharmacist in all those places, you could do a warm handoff perhaps through a video, a two-way video chat in the office where you say, we are going to ask you to see this pharmacist in this community setting. So those are the kinds of things that are harder to solve than the most obvious thing is that the highest performing medical groups in California pretty much all have pharmacists on the care team in the integrated setting. But in the non-integrated setting, which is the norm, it's much harder.
So I think that's my point on the community pharmacy.
Utilize your community pharmacy.
That's where I want to go with community pharmacy, because to get to the IPAs, that's the difficult thing. That's the next, I think that's the next challenge. It's either the community pharmacies working with that, and the other idea that I've been trying to get people to kind of latch on to, it's a mobile pharmacist. It's a shared resource, amongst things. So I think we're getting to a whole other level of this is, to me, fun to actually address that challenge. I think it's going to be very different.
Have you, curious, the group I manage is Telefon, the pharmacists, nutrition, health coaches.
Are you Sutter?
Yeah.
Yeah.
Yeah, telephonic disease management is the name of the program. And been around since '98, so it's not a new entity, but we started our hypertension program in earnest about 2 years ago, had diabetes for about 12, 14 years now. It's completely telephonic. Now we have pharmacist partners at the various care centers, but we're able to manage, we've got 65 or 70,000 people assigned to us now. And we use our EPIC data, as you say, to let us know when somebody's out of control. So we don't graduate people. There's only one way to get out of our program, and that's toes up. So, and that means we didn't do our job. But anyway, so I'm curious as to whether or not, I think one of you, as you alluded to, that you're starting to reach out a little bit by phone. our experience is it gives us the ability to use everybody within their scope of practice. You just mentioned that back there. So we've got 2 clinical pharmacists now, and we use them when you've got a polypharmacy situation, a lot of comorbidities. The RNs have kind of hit the wall. We've worked with a couple of providers. That's where, when I went out to get pharmacists, I knew that kind of intuitively, I'm a nurse actually, so that's where I wanted to go with that. It works very, very well. But they are also trained in motivational interviewing. They're working with patients one-on-one. But I'm really curious is if you're using people within different scopes, using a coach to keep the patient kind of bridging that gap between pharmacy visits. You use nurses, you use nutritionists, other things depending on the patient's needs.
Can I speak to that?
Yeah.
Yeah.
So I'm Linda, one of, like Rosemary and Paul and I are in actually a different department within the university. The 3 of us are pharmacists with health management and education. And our department is solely, we're basically initiated as a case management. So we had nurses and social workers. And about it's been 4 years now, I think. 4 years now, they brought a pharmacist on board onto the case management team, and that was myself. I started out as 50%, now we're 2.5 FTEs in. We're purely telephonic, we're solely telephonic. We support the PCNs just like Stephanie's and our ambulatory care pharmacists do. And it's actually a very successful collaboration because a lot of physicians will refer their patients with multiple disease states and chronic diseases to the social workers and the nurses, and then from them they go, Linda, help me with the next. So that's sort of how we get our patients, is we get referrals from the PCPs as well as our case management colleagues. So it works actually very well. We've expanded it to hypertension management, and I think Pharm can speak a lot better to that, where they use an eye health and it feeds into our EMR and
the Apple Health Kit, and I'm happy to share with you more about the flow sheet. So at UC Davis, we do have a patient-generated health data flow sheet that allows blood pressure, weight, and glucose into the EMR. It's under an outpatient flow sheet, and while the patient is in our program, we open up that flow sheet, but of course there's a liability issue, so we do close it out once the patient receives the education and the management. And if they're still uncontrolled, then we route it back to usual care or the ambulatory case managers. And we are working and we're continuing to expand and work in collaboration with the PCN pharmacists to do a warm handoff. I think earlier there was a question about how, what do you do after you return to usual care. So there's a workflow in place that we're hoping to continue to support the physicians and the patient. And then to the question of, if you're an independent physician out in the community, what other resources? And I think community is one, but perhaps, Sutter, I train as a resident of Sutter, but working at UC Davis, and was at Kaiser as a clinical health educator, so haven't seen like the different top-down approach, wide approach. I think one of the concern is cost, right? So I think a telephonic team may be a more centralized option and more cost-effective option, but also partnering with the in-person pharmacist or care team if available. So that may be an alternative, and so expanding your team more to support the certain independent physicians.
Yeah, and we do. We work a lot with them. The biggest challenge, you were asking about challenges, and you mentioned it, it's getting data. And so whether it's nurses, case managers, or pharmacists as case managers, if our SIP, primary care, specialty providers aren't in Epic with us, we're blind to some of what's going on. Is it current data? Is it not? Can we even get it? And then we get a little nervous when we're relying solely on patient-reported blood pressures. Where the legal risk issues, when you dive in there and you make a recommendation, and if you're under a CPA and you make a change, is it really safe to do that if you don't have all the information. So that's one of the areas that we're still exploring with ours. So it sounds like you kind of have and certainly the community pharmacy issue, the vast number of EHRs out there. How do you get that data?
I'm just wondering, we have a couple of representatives from the American Heart Association with us. You've been working really hard on the data issue, get the guidelines, inpatient and outpatient. I don't know whether it's Mike or Andy that should address the question, but do you have something to offer?
Mike, but what on my side, where QSI I deal with the guidelines.
What's QSI?
Sorry, quality and service improvements. So as I was listening to this and being pretty new to it, I kind of hear the tie-ins and how, you know, the connections between all the different departments, and it's what Get With The Guidelines is all about, the hospital setting. But I keep thinking about, like, wow, I can kind of see how how much alike it is when it comes to those kinds of things.
Yeah, when it comes to the primary care setting, I mean, that's the biggest issue we have to do with this data. Everyone has different systems.
Yeah, exactly.
And so the hospital's completely different.
It is.
From what I'm working with their, BCP.
For
So
sure.
It's a confidential app right now, so.
So you don't have a solution.
I don't have a solution.
No.
But
the way I look at it is the way the data is collected and compiled, and then the departments talk to each other, and how the flow is. And I think that's what we're talking about here. I'm coming from more of a pharmaceutical background, but the flow of it, I've seen it from the other end, how it doesn't always flow very well in primary care, especially, it can be tough. But that certainly would get with the guidelines in my mind as I see it fitting. It's very, apropos.
But I think what AHA does also have, Mike, if I can talk about on this, is they have a check change control program, not in every city, but certainly in the Bay Area we have it. That is a free app and portal that the patient can activate, so they can go online, they can enroll in check change control, they can invite their health coach to check change control, they can invite their physician to check change control. And the piece that Mike and I have talked about a lot, but that's still that little gap, is the data can move from the Bluetooth cuff into check change control. The health coach can help the patient get these things set up, as was well described by you guys. But the physician doesn't want to log in the portal at the other end. In fact, they have told me basically, NFW, I'm not doing it. Not going to happen, I don't have time, right? So the natural right now at the medical groups has been, maybe that's another role that the pharmacists would be able to take on, as a way to look at those data and extract only the abnormal data, because as you've seen from Rose's presentation, and Marilyn has said this to me, there's people who will put their blood pressure in 20 times a day, even if it's normal. So we don't need all of the data. We really only want to act on the abnormal data. So I think there's a lot of potential with check change control to really start to fix this data flow problem.
So I just want to point out that we have a new epidemiology fellow from the California Department of Public Health who emailed me at 10:30 this morning to say she'd be happy to speak today, and she has a document that she wants to flag for us.
on everybody's,
There should be one on every table, and we will be sending it out later, so don't feel like it's a big deal if you don't get the one copy. But I think it's important to highlight this because we're kind of talking about the why, and obviously what's really important, and this document is kind of talking about the what, in terms of what CMM exactly is. So this is out of mostly the University of Michigan. You can see on the inside cover the three kind of leading researchers working on it, and I spoke with Todd Sorensen of University, sorry, not Michigan, Minnesota. Forgive me. Last week about this document. Essentially what he's saying is kind of, the Dr. Roberts spoke about a definition of what CMM is in Oregon, so he's kind of covering that. And it's kind of, so starting on page 7 is the essential functions, and they have 5 essential functions of what CMM exactly is. And it's also important to point out that they're doing this out of Minnesota, which is where they call MTM there, but it matches our definitions of CMM. It's actually covered. Legislation makes it so it's covered in Minnesota, and their and the definition is also matches like what has been proposed in California legislation to be covered as CMM for Medicare. Thank you.
So this is just a, yeah, you didn't hear me. So this is just an important document to kind of refer to. We're hoping that he's hoping will go out pretty widely to kind of standardize the definition of what the essential core function are of CMM. And they're also working currently to create a self-assessment tool for physicians and pharmacists who are doing something around CMM to self-assess if what they're doing meets the standards of CMM based on this definition. And that's coming out probably in September, and hopefully spread widely as well. So that would be a good tool for physicians and pharmacists to use as well, so that it can be standardized from there. Yeah.
So thank you for that brief overview. We would love to have the California Department of Public Health, when they can, come back to talk about the white paper that they work with pharmacists across the state and country to gather all the relevant data and really emphasize the importance of adding the pharmacist to the care team under the leadership of the former Secretary of Health, Diana Dooley, who's now the governor's chief of staff. And I just want to flag for everybody that there is a piece of legislation, SB 1264, that Susan is going to talk about right now. It's worth staying a couple minutes to hear about it.
We won't make you listen to the policy stuff, but we do love it. Thank you, Rose and Stephanie, too. So a couple of the items that have come up that people are concerned about, besides interoperability, which we all are concerned about, are how do you pay for this? So I got this lovely slide from Steve Chen, who couldn't be with us again, talking about all the different mechanisms. So there are the cost savings and the returns on investment that we talked about for decreases in acute care utilization, both emergency department visits, hospitalizations, but also decreases in long-term care. Some direct billing mechanisms that are now coming up, the Los Angeles County Department of Mental Health is now paying 85% of the physician payment rate for pharmaceutical, pharmacist management of psychiatric medications. There's gain sharing programs, pay for performance, meaningful use, Medicare quality payment. These are all ways that money can come back into the practice that can get redistributed. It does in my practice. We don't give that back to the clinicians. It goes for other things in our practice, to pay for other things in our practice. In addition, one person was talking about the balance between your managed care and your traditional fee-for-service. Medicare has implemented a number of new codes under their traditional fee-for-service billing that we all can take advantage of. Codes for providing diabetes prevention program services, which can certainly be provided by nurses and pharmacists. Chronic care management, which this kind of care of medications can fall under. Care transition, so transitional care has its own billing codes now. Annual Medicare wellness visits have special codes and costs, and again, you can have different people in your office providing those services. And a new one in 2018, the remote monitoring codes, the 99091, that we can use specifically to gather back in some dollars related to services that we're already doing on the phone or long distance in terms of looking at blood pressures, people's home glucose monitoring, and other types of measures like that. And in the 340B program that Jan mentioned a little bit earlier. The two bills that Hattie's referring to, one is SB 1264, which is a hypertension management, medication management by trained pharmacists for Medi-Cal patients who have uncontrolled blood pressure. And the status on that is that it's passed through the Senate and Assembly Health Committees and now waiting for Assembly Appropriation Committees. There's some groups that are supporting it, some groups that are taking sort of a neutral stand like CNA and AAFP, but at least one group that's actively opposing, which is the Southern California chapter of American College of Cardiology. So it may be a little bit tougher to pull this one through, but I think the evidence that we presented today shows that there's a lot of evidence on the side of having hypertension medication management done by trained pharmacists. Also, SB 1254 is a mandate for pharmacists to provide medication reconciliation services in hospitals, and this contributes both to better management during hospitalization, but also at discharge, doing that new medication reconciliation when new meds have been prescribed, and then transmitting that information back to the primary care provider, or in the case of the Hawaii demonstration project to a community pharmacist as well. This bill has no